you. All right, we're gonna just briefly again go over some of the definitions and classifications for TGCT. Just kind of go into the gross and low power histology, take a little interlude to the molecular background to kind of help you understand what you're seeing once we go to higher power histology, the various cell types that are at play here. We'll talk about the ancillary testing and sort of the clinical implications is what we'll end with. All right, so tenosynovial giant cell tumor, this is a group of lesions arising from the synovium of the joint space. Again, and it can extend out into closely related and approximated structures, so including tendon sheath and bursae. Various sorts of classifications, but the main ones that we use right now are, is it localized disease versus diffuse disease? And is the location of the disease within a joint space, intra-articular, or encompassing spaces outside of that joint space, so extra-articular. And again, the related antiquated terminology that we discourage use of in our reports would be giant cell tumor of tendon sheath and pigmented villonodular synovitis, PVNS. My philosophy is that if you have a tumor like this that you're diagnosing, as a pathologist, when I put out my report, what I will say is tenosynovial giant cell tumor. But especially if I know that a report is going out to somebody in the community who maybe doesn't see this type of disease process on a daily basis and maybe knows some of the other terminology, I'll kind of put that in parentheses. So a lot of people are, familiar with PVNS. So if that is what it looks like on imaging and histologically and clinically, then I might put those terms in parentheses. But again, for a diagnosis, really encouraging the unification and usage of the terminology of tenosynovial giant cell tumor. All right, so a synovial joint space, there's a lot going on. It's a confined space. We're dealing with a lot of different tissue types. So we've got our cartilaginous menisci and articular cartilage. We've got obviously our synovial line space in the joint cavity. Then we have tendons and ligaments that are interfacing directly onto the bone and around the joint. So again, this is why a disease that starts even in the joint space, because there are so many other structures converging onto a synovial line joint, that you can have the disease extend out of its joint space and infiltrate into those adjacent structures. What normal synovium looks like is you're going to have the synoviocytes, so the actual cells that comprise the synovium, are generally anywhere from 1 to 3 layers thick. Underneath that synovial cell layer, we have a lot of capillaries. So the way that a synovial line spaces essentially gets all of its nutrients and all of its supplies to maintain and repair itself comes from diffusion from these capillaries. So the capillaries are very, very important, and also very important to the disease process. And then in sort of the background, we have this loose base connective tissue. And if we go deeper in the joint space, we'll see a little bit of fibroadipose tissue or fat. All right, so localized TGCT, most common in the hands. Again, ages are going to be around 30 to 50 years, slight female predominance with the localized version. And most of the symptoms that you're going to see are going to be due to the mass effects. So often patients come in with longstanding painless swelling. From a low power view, when this is excised, what it looks like is a very multinodular type of tumor. It's going to be very well circumscribed. So gross histology very much, mimicking what we see underneath the microscope. Again, very nice parallel. What we have is multiple nodules of tumor. Again, nice circumscription. And you'll see histologically, this looks very, very different from what a diffuse TGCT looks like, both clinically and underneath the microscope. And we'll kind of talk about, when pathologists name things, especially prior to having a lot of the molecular testing and other available ancillary testing, what we did was just put names, very descriptive names to what we saw. And so we'll kind of get into why a disease process was called PVNS and kind of break that down. So for diffuse TGCT, this is going to be involving the large joints, with the knee being the most common. Extra-articular disease is going to be present in this scenario more commonly. The patients that are afflicted by this are going to be younger, tend to be younger than the localized version. And in addition to the mass effect that you have from the presence of a tumor in a confined space or area, because these have a little bit more growth potential, you're going to see a lot more additional symptoms such as pain, tenderness, and joint swellings, effusions, or hemorrhage. All right, so in contrast to the nice circumscription that we saw with the localized version, what we see here is a lot of villiform structures, so little nubbins that are kind of coming out of the tissue plane. Again, very diffuse growth. We don't have a nice circumscribed growth. And then when we look at it histologically, what we see are these villiform structures. So in addition to the brown pigment that we see, so hence the pigmented component of the name, the villiform, the villus component, and then of course you have the nodules of the tumor itself. So kind of makes sense why these were called pigmented villonodular synovitis. And obviously synovial component reflecting the last portion of that name. All right, very briefly, since this has already been covered, CSF1 rearrangement has been the main driving force for these tumors. CSF1 is a gene on chromosome 1, and what it does is that a portion of that gene from chromosome 1 will actually go to another chromosome and fuse with a different gene. The most common partner is the COL6A3 gene on chromosome 2. However, as we're starting to sequence more and more of these tumors, what we're realizing is that the CSF1 gene can have a lot of different partners. So even though the COL6A3 gene is the most common partner, there are other common partners that are being described every single day. And so as previously stated, you have the fusion of the two genes and essentially leads to development of a protein or even an increased expression of the protein. And the increased expression is really what we see with this disease process. So the translocation of the CSF1 gene happens within a synovial cell. So a synovial cell that has this translocation is what we consider neoplastic. And neoplasia is just, if you break down the term, just means new growth. So, and it does mean it's a clonal proliferation. So each synovial cell that is implicated in this disease process will have the same genetic translocation, and that is the translocation of the CSF1 gene. So with this translocation, these synovial cells make way too much CSF1 protein. All right, so we've got that as the starting genetic event, and its effect is way too much CSF protein. All right, so the CSF protein interacts with its receptor, right? So the protein has a receptor. Those receptors are found on macrophages. And so because these synovial cells are making so much CSF, these macrophages come into that joint space, into that tumor environment, and start to proliferate. So once the CSF1 is bound to those macrophages are recruited, and then they start feeding into the disease process by releasing additional mediators. And when you guys, with the next lecture, once you start talking about various targets, you'll see that some of the mediators that the macrophages themselves release can also be targeted as a potential therapeutic mechanism. All right, and so this all ends with a proliferation of, again, your synovial cells that have the translocation. Those are the truly neoplastic cells, and the macrophages that come in have essentially been recruited. So you get a mixture of both neoplastic cells and immune cells that are recruited into making your tumor proliferate and essentially grow and cause the downstream symptoms that patients experience. All right, so what does this look like histologically? So in this field, for comparison, we've got native synovium kind of running up top, and the majority of the cells that you see in here, this is a nice portrayal of one, but the majority of the cells that you see in this field are those neoplastic synovicytes. And so we have the two different cell types, the two main cell types that we look for in this tumor, the neoplastic synovial cells and the recruited macrophages. But even moving within a tumor, if you go from one area of the tumor to a different area, there can be an interplay of both cell types, or one cell type can be predominant. So even within one patient's tumor, different areas, if you look at it under the scope, can look very, very different. So there's a lot of what we call intratumoral heterogeneity of what cell types might be present in the field that you're specifically looking at that time. So this field is entirely comprised of those mononuclear neoplastic synovial cells. In other areas, you may have more of the tissue being overrun by the macrophages, and the macrophages take on a few different looks. So here's what we call when they're foamy. So essentially what they've done is the role of macrophages in your body, they're a scavenger cell. So they essentially are just engulfing debris, clearing it. And so when they engulf anything that is lipid laden, their cytoplasm tends to accumulate those lipids. And that's what we call that foamy look. Again, a very just generic description, but in certain areas of the tumor, you might see an overrun of foamy macrophages. And again, what gives it that pigmented look is when the macrophages, instead of having that foamy appearance, start to engulf a hemosiderin, which your synovium is really, really richly vascularized, right? If you have any sort of growth, chances are you're going to be disrupting those capillaries. Well, capillaries bleed, you're going to get a lot of red blood cells. And once those red blood cells start breaking down, sort of the hemoglobin, the end effect of breakdown of hemoglobin is going to be hemosiderin, which has a very characteristic brown appearance in tissues. And your macrophages, being the scavenger cells that they are, will go up and try to clear out the hemosiderin, and their cytoplasm will be filled with the hemosiderin. So in certain areas, you'll have more of the hemosiderin-laden macrophages. And then, of course, you're like, why have you not talked about giant cells yet? Well, giant cells are really just fused macrophages. And we call them giant cells because they're obviously very, very enlarged to accommodate the numerous nuclei that they have. So this is one that's a little bit degenerative, but again, you can see the many, many nuclei within one giant cell. And this comes from the macrophages themselves fusing. And so essentially it's still the same macrophages that are recruited, but just again, macrophages within the tumor can look very, very different. All right, so some of the ancillary testing that we use, I'll just very briefly describe kind of the background for it. And since we love to use our acronyms, one of the techniques that we use is called immunohistochemistry, or IHC. With our ancillary testing, what we try to do is essentially look at different elements within the cell. So we can look at the protein level. We can go a little bit more granular and look at things that are happening at the RNA level, or we can go even more granular and look at things that are happening at the DNA level. So immunohistochemistry, or IHC, tells you what's happening at the protein level. So at the end of whatever protein genes are expressing, that's what we can sort of interrogate. And you interrogate that by having a primary antibody that interacts with the protein of interest that you're looking at. And then you have a secondary antibody that's tagged to a chromogen. And once you have both antibodies bound, essentially the chemical reaction releases a color. And if you have that protein, or if it's lost, depending on what you're looking for, that's what your IHC tells you. And so it'll have a nice color change. Generally, brown is the color that we like to use. It's easiest to see. And so if your protein is present, you'll get a nice color change, and the presence of that protein will be registered. The other technique that we use is called fluorescence in situ hybridization, or FISH. And specifically what we can use this for is looking at generally the DNA level. And what we're interested in this particular disease process is the CSF1 gene. And since it's there's a translocation of it, and it goes from its native gene to a different gene, what we're looking for is breaking apart of one of the genes for CSF. So in a normal state, you would make a probe for the two different ends of your gene. And in its native state, what you should see is that the two ends are where they need to be on the same chromosome. So what you'll get is two fused signals. However, when you have translocation of the CSF1 gene, it's going from its native chromosome 1 to another chromosome. What you'll see is that one of the gene signals is split apart. And so that's what you'll see optically, is that you have one fused signal and then one signal that is broken apart or split. All right, so how do we use this? So we can use CSF1 and interrogate it both at the protein level with IHC or at the DNA level by using FISH. And so since most TGCTs have a CSF1 fusion, we can use IHC if we so need, or FISH. So IHC appears top. And again, the CSF1 protein, you're seeing it not expressed in every single cell, right? And that again goes back to what the tumoral milieu is, because only your synovial cells are the neoplastic ones. So the protein, we're checking for the neoplastic protein in the neoplastic cells. So in all of the macrophages that are in the background, obviously there will be no expression of that protein. It's only going to be in the neoplastic synovial cells. Same thing with the FISH. And this is kind of what that schematic looks like in real life with the fluorescence microscope. We have one fused signal there, and then one signal that's split apart. So this tells us that, yep, we have a translocation involving the CSF1 gene. So that's very nice that we have these tools available. However, because we are dealing with such a rare disease, these tools are not widely available in every single laboratory. And I've only ever really had to send for CSF1 mutational testing one time. And that was in just a very confusing case where there was just a lot of clinical factors that were confounding. But generally, you don't need either of these modalities for diagnosing. It's generally good enough to have the imaging, the clinical history, and then the histology based on either a biopsy or a resection specimen for diagnosis. This is another protein that's involved in this tumor that we could use. It is a little bit more widely commercially available, but again, just not commonly employed because you don't necessarily need to go to this level to be able to diagnose TGCT. So this is clusterin is a protein that's expressed again just in the neoplastic synoviocytes. It's a chaperone glycoprotein that just is involved in a little bit of lipid recycling and managing cellular damage, not important to know. And again, this is available, but not routinely done. What we use is really imaging, clinical data, and what we see histologically. All right, so in terms of clinical implications, very rarely do we get biopsies of these lesions. And it's generally in the scenario where maybe the clinical picture is a little bit confusing and we're not exactly sure of the underlying etiology. So what we want to do is rule out other lesions of the synovium. Rarely malignancies can involve the synovium. Obviously, infection being important to rule out, and an inflammatory synovitis being important to rule out, since the treatment will be so different for any of those entities. So when making a diagnosis on such a limited biopsy, again, you want to make sure you've ruled everything out, and then you really want to correlate with the imaging. Does it look like I have a mass-like lesion, or does it look more inflammatory? And so having a good relationship with your radiologist, and obviously having a good relationship with the person who is seeing the patient, whether it be sports medicine or another orthopedic specialist. Just having those conversations is really good when diagnosing on a very limited amount of tissue. The localized type is really amenable to complete excision and ideally should not recur, since the disease can be gotten around. The diffuse type, just by the nature of the beast, there is going to be residual disease left over. You're going to have positive margins, so to say, and these will be prone to recur. And they might even progress to a worse disease. And by progression, essentially what I mean, the worst thing that could happen is malignant transformation. Now, this is, again, we're dealing with a rare disease. This malignant transformation is going to be even more rare. It's extremely uncommon. The cases that have been described, and I, in all my years of practice, have never seen a malignant TGCT. So it's really just case reports out there. But when we do see them, what we see them is arising in a pre-existing TGCT that has recurred and then gotten more genetic anomalies and aberrations, more mutations, and that's the accumulation of additional genetic events causes it to kind of change and become malignant. But again, very, very, very rare. Histologic features, and I'll show you a case in the next slide. Instead of the admixture of cells that you have with the atypical and with the neoplastic synoviocytes and the macrophages, if there's malignant transformation, because you have so much proliferation of the synoviocytes, generally what you will see is really the giant cells, the macrophages, will kind of be shuttled out of the tumor environment, and it'll just be the atypical synovial cells, just sheets and sheets of them. And essentially, they can very much represent a high-grade sarcoma histologically. The few cases that have been described, these are aggressive tumors, and they can metastasize to lymph nodes and to distant soft tissue. All right, so this is a case of a malignant TGCT of the fingers. And again, the tendinous portion of the fingers on both digits, you can see has kind of been eaten away by this very infiltrative and destructive tumor. And obviously the patient underwent an amputation for this. And once we look at the tumor cells histologically, again, you're not seeing any of those macrophages being involved. We're not seeing any of those giant cells. Again, they've all been pushed out because what we have is a proliferation of your neoplastic synovial cells. And in contrast to, what we saw previously, these are very, very large and have what we call nuclear atypia. So their nuclei just look, frankly, malignant. All right. So hopefully that wasn't too much histology for you guys. And hopefully cleared up what we see, histologically. But any questions?